Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're doing another Kahoot, and we're going to be covering the differences between diabetes insipidus and SIADH, syndrome of inappropriate antidiuretic hormone. I just said a mouthful. Anyway, we're going to go over the pathophysiology, treatments, and of course, most importantly, the nursing interventions. Now, before we get started, as always, I'm going to ask you to please support me and support this channel. How? By liking this video. You're going to love it. Go ahead and give it a thumbs up now so you don't forget. Subscribe to my channel if you haven't done so already. And be sure to check out my website, nexusnursinginstitute.com. There, I've got so many resources. You can sign up for a Next Generation NCLEX review session, part 1 and part 2. In part 1, I teach you how to think critically. I teach you about prioritization and delegation, different situations NCLEX may present to you and where your brain is supposed to go with that information. In part 2, we go over NCLEX types of questions, rationales, and how you should apply them to the type of questions that you receive. You can also sign up for an audio lesson. Well, many audio lessons. If you're a current student and you're really struggling, you have to do really well on your next exam. Look at the audio lessons that I have, look at the descriptions, and see if any of my audio lessons match your upcoming exam. Thank me later. You can also sign up. What else can you sign up? Oh, private tutoring sessions. You can sign up for one-on-one private tutoring sessions with me, or maybe just a consultation session. You want to pick my brain about something. You may need advice about something in the nursing field. I'm the person to ask. So again, nexusnursinginstitute.com. Very, very soon, coming down the pipeline is going to be my Nexus Nursing Test Bank. That's going to be for PN, VN, RN, and nurse practitioner students, okay? So if you're studying for your NCLEX or your NP certification exam, very soon you can go over the important topics that you need to know and practice questions on my website. Almost daily, you can find me covering a variety of nursing topics across my social media platforms such as TikTok, Instagram, Facebook, YouTube. My handle is the same everywhere, Nexus Nursing. Without any further ado, guys, let's get started. SIADH versus DI. First question. Okay, what is the pathophysiology of SIADH? Please drag and drop each step in the appropriate order. If you are on the Kahoot, go ahead and drag and drop the step in the appropriate order. If you're on the live, just put what colors go in order, guys. The pathophysiology of SIADH, syndrome of inappropriate antidiuretic hormone. Can't read the last option. Oh, I'm sorry. There you go. Sorry about that. The last option says dilutional hyponatremia and decreased serum osmolality. Sorry. Only 26 of you guys got this correct. Let's talk about this, the pathophysiology of SIADH. Well, the first thing that happens is the patient has way too much antidiuretic hormone, also known as what? You can see it be called as vasopressin, okay? They have way too much antidiuretic hormone. Well, why is that an issue? What does antidiuretic hormone make you do? It makes you hold on to your fluids, right? Instead of releasing your fluids via urine, you're holding on to all your fluids. So that's the first problem. You have too much ADH. Having too much ADH causes what comes next: increased water reabsorption in the renal tubules. So you have too much ADH. And so what happens is the kidneys, which is supposed to allow you to release the fluid via urine, instead of doing that, because it could do one or two things: release the fluid or reabsorb it. It reabsorbs. Now, you see that word reabsorption? Be very, very careful, because for testing purposes, guys, one letter will make you get it wrong. There is a difference between reabsorption with an A or resorption without an A. If there's an A and it says reabsorption, that means to take back up, right? So when it comes to the fluid, the kidneys make the body take the fluid back up. If it says resorption, resorption means to let go. Big difference. That one letter will be the difference between you getting question right and wrong. Okay. So we have increased antidiuretic hormone, which causes increased water reabsorption. You're holding on to the fluids. The kidney's not letting it go, which leads to increased intravascular fluid volume. This is also important. Notice I didn't say increased fluid volume. I said increased what? Intravascular volume. That word intravascular is very important to you. What? That tells you not only are you holding on to the fluids, it tells you where you're holding on to the fluids within the vessels. So you're not releasing fluids, you're holding on to the fluids, but specifically in the vessel. So even though the patient's holding on to fluids, they're getting heavier, they don't look swollen because the fluid is not in the tissues, it's in the vascular space. So we're going to be worrying about things like, hypertension and other issues because it's where? In the vessels. And then last, dilutional hyponatremia and decreased serum osmolality. You need to understand why. You cannot memorize in nursing, guys. There's too much to know, but you have to, if you understand, you'll always get it correctly. So let's think about it. Dilutional hyponatremia. Okay, why are we having dilutional hyponatremia? Okay, patients got too much antidiuretic hormone. It's making them hold on to too much fluid. That too much fluid is where? In the vascular space, not in the tissues, in the vascular space. Well, guess what else is in the vascular space? Things like chloride, things like sodium. So you have all this fluid that's flooding the vascular space. So your sodium that's supposed to be 135 to 145 gets diluted because of all the fluid. That's why it's called dilutional hyponatremia. Yes, the sodium is low, but the sodium is low. Why? Because of all that fluid. And decreased serum osmolality. This is something else that you guys seem to really get confused of. No, that's not good English. You really get confused with as students. So let me clarify, guys. You have urine osmolarity and you have serum osmolality. We're talking about serum osmolality, serum blood. Okay. So we're talking about the blood here. Why is the serum osmolality decreased? Here's why. Think about it. You got way too much ADH. You're holding on to way too much fluid within the vascular space, right? It's diluting the sodium. So guess what? Sodium chloride, all those particulates that would make the serum nice and thick, it's being diluted. So it's not going to be nice and thick. So that serum osmolality will be what? Decreased. If it was concentrated, it would be increased. Okay? Are you guys following me? Okay, I'm moving on. All right, let's talk about DI. What is the pathophysiology of DI? Again, drag and drop each step in the appropriate order. Here are your options: decreased water resorption in the tubules, decreased intravascular fluids, decreased antidiuretic hormone, increased serum osmolality, hypernatremia, and excessive urine output. New student nurses are more than welcome. Thank you to everyone that's sharing the live. Thank you. Okay, you guys did much better than before. Okay, 47 of you guys got this right. The pathophysiology of DI. So in SIADH, remember the patient had way too much antidiuretic hormone. They were holding on to their fluids. Well, guess what? Diabetes insipidus, DI, is the opposite. They don't have enough antidiuretic hormone. And because they don't have enough antidiuretic hormone, they're urinating all over the place. They're getting rid of all their fluids. When you think of DI, I want you to think of Oprah Winfrey. You know how Oprah Winfrey is always giving things away? DI is always giving urine away. You get urine, you get urine, you get urine. Everybody gets urine, right? This patient's going to be severely dehydrated because they're getting rid of all their fluids. Why? They don't have enough antidiuretic hormone. So that's the first step. That's the first step of the disease process, not having enough antidiuretic anti-diuretic hormone. Now that leads to decreased water reabsorption. Again, that A makes a big difference. I didn't say resorption, I said reabsorption. Instead of reabsorbing, pulling all that fluid back into the body, what do the kidneys decide to do? Let it all go. Why? Because there's not enough anti-diuretic hormone to make you keep it. So now there's decreased water reabsorption in renal tubules, which allows all that fluid to leave the body. So guess what that leads to? Decreased intravascular fluids. Again, I could have just said decreased fluids. No, but no, I'm telling you, for testing purposes, you need to know where that fluid is going, right? So it's not fluid that's in the tissues. This is fluid that's in the vascular space. Dehydration is a big deal. Hypotension is a big deal. Everything that comes with decreased fluid in the intravascular space, you're going to be concerned about, which leads to what? Increased increased serum osmolality, hypernatremia. Let's think about that part, and then we'll get to the second part. Within that vascular space, all the fluid is gone. All that's left are those particulates, such as, sodium and chloride. So yes, we're going to see increased osmolality, right? But excessive urine output. So urine output is up because patients urinating all over the place. Serum osmolality is up. Guess what's down? Urine-specific gravity. This is very important. I promise you're going to be tested on it somewhere. If you're taking this, you're studying this right now, it's going to be a test question. You better know that. Let me explain this to you. DI, you're urinating all over the place. You're getting rid of all your fluids. So your urine output is increased, right? But even though you're getting rid of all this fluid, all of those solutes, all those particulates are staying in the blood. So yeah, you got a big amount of urine output. You're urinating all over the place, but the urine is very light. The urine-specific gravity is very, very light. Why? Because everything stayed in the blood. All you're getting rid of is the fluid. So urine output up. Serum, the blood, serum osmolality up. But urine-specific gravity, the solutes that's supposed to make the urine heavy, remember, it stayed in the blood. So the urine-specific gravity is going to be what? Down. Okay? You guys follow me? Okay, I'm moving on. Select all that applies. Which are important nursing interventions for SIADH? So we're talking about syndrome of inappropriate anti-diuretic hormone. Which are important nursing interventions? Here are your options. Watch out for low urine output and high specific gravity. Watch out for sudden weight gain without edema. Monitor the INO. Obtain daily weights. Observe for seizures, headache, and vomiting. Observe for decreased level of consciousness. Select all that apply. I forgot to type it, but this is select all that apply. We're talking about nursing interventions for SIADH. Select all that apply. Okay, so let's talk about it. All of them. Remember, SIADH, syndrome of inappropriate anti-diuretic hormone. Patient has way too much anti-diuretic hormone. They're holding on to all their fluids, and the little bit that they urinate is full of solutes. So that patient with SIADH, even though urine output is down, because they're really not urinating, the urine-specific gravity is up because all the solutes have gone in the urine. With that being said, first one, watch out for urine output with high specific gravity. Yeah, SIADH, they're not urinating much, but the little bit that they do let go is going to have a high specific gravity. All those solutes have left the blood and went in the urine. True. Watch out for sudden weight gain without edema. Yes. Why did only 51 of you guys, no, I'm lying, 61 of you guys said yes on that, but it should have been more. Think about it. Remember SIADH, you're holding on to fluids. Fluids where? In the vascular space. That fluid's going to make you heavier, but you're not going to look swollen because the fluid is not in the tissues. It's where? In the vascular space. Monitor for intake and output. Of course, if we're treating this patient for SIADH and we know that in SIADH, the patient's not urinating the way they're supposed to, aren't we going to do INOs to see if they're getting better? We're going to count how much fluid is going in versus how much is going out. Of course we are. Obtain daily weights. I'm so happy the majority of you guys said yes to daily weights. Let me tell you something. When it comes to DI, when it comes to SIADH, when it comes to CHF, when it comes to any disorder that has to do with patients holding on to fluids, when it comes to burns, when it comes to any disorder where the patient's holding on to fluid, the number one way to assess a patient's fluid balance is always daily weights. It is not INO. It's not skin turgor. We're still going to do INOs. We're still going to check the patient's skin turgor, but the number one way to assess the patient's fluid status is always going to be daily weights. You're going to take that patient's weight in the morning, same time, same scale, same type of clothes, every single time. Moving on, observe for seizures, headache, vomiting. Absolutely. Why? Those are signs and symptoms of what? Hyponatremia. Remember, your sodium is supposed to be 135 to 145. And when I say your sodium, I'm talking about sodium in the blood. That's what it's supposed to be, 135 to 145. But because the patient's got way too much antidiuretic hormone, because they're holding on to way too much fluid, that sodium gets what? Diluted. And they have what? Hyponatremia. Want to know those signs and symptoms of hyponatremia? You're looking at it. Seizures, headache, vomiting, and changing level of consciousness. Patient may become lethargic. Make sure you know those signs and symptoms. Nader Dog says that's why I be hella skinny in the morning. I don't know about that. Okay. So make sure you know the signs and symptoms of hyponatremia for SIADH because you're going to be watching out for that. And of course, observe for decreased levels of consciousness. All right, type in your answer. Your patient has diabetes insipidus. Would you expect Lasix or DDAVP to be ordered as treatment? Your patient has DI, diabetes insipidus. What medication would you expect to be ordered? Would it be Lasix or would it be DDAVP? Well, I'm not going to tell you until the results come out. Okay, very good. DDAVP, guys. This is an ADH, an antidiuretic hormone analog. And so this is what we expect to be given because guess what? It's the hormone replacement of choice. You know how you have a drug of choice? This is a drug of choice. This is the hormone replacement of choice for the patient that has diabetes insipidus. Okay, it helps replace that hormone of the antidiuretic hormone because what's happening here in DI, they don't have enough of that antidiuretic hormone. That's why they're urinating all over the place. All right, select all that apply. What is SIADH characterized by? Select all that apply. We're talking about SIADH. Here are your options. Fluid retention, excess urination, dilutional hyponatremia, concentrated urine, increased urine-specific gravity, serum hypoosmolality. What do you think? Select all that apply. We're talking about syndrome of inappropriate antidiuretic hormone. What are the clinical manifestations, the signs, symptoms we expect to see? Okay. Most of you guys got the first one right. Fluid retention, SIADH, they have too much antidiuretic hormone. They're holding on to the fluid. They're going to have fluid retention. Very good. So if they have fluid retention, the urine output is going to be low because they're holding on to fluids, right? So no on excess urination. Very good. Dilutional hyponatremia, yes, because they're holding on to all the fluid and all that fluid is diluting the sodium. So the patient will have dilutional hyponatremia. Yes. Concentrated urine, yes, because they're holding on to all their fluid. But the little bit of fluid that they do let go of is going to be concentrated because all the solutes that were in the blood are now in the urine. So guess what? Concentrated urine, increased urine specific gravity. I'm talking about the same thing, okay? Increased urine specific gravity, yes. Why is it so heavy? Because of all the solutes that's in the urine. That's why it's concentrated, duh. And last, os serum osmolarity. Hi, I can't speak. My gosh. Forgive me, guy. If you're new, I apologize. I have a speech impediment. I was born with it. I can't help it. But I know what I'm talking about, I promise. Serum hypoosmolality. True. Serum, we're talking about the blood. Hypo, a little bit of osmolality, the solutes. There's a little bit of solutes in the blood. Why is there only a little bit? Because it's all in the urine. That's why the urine specific gravity is high. All those solutes left the blood and went where? To the urine. Thank you, Maisha. She says I have the same list. Well, I'm worse. I have a list. I can't speak. I have everything, but thank you. Okay, true or false? Indomethacin, which is an NSAID, helps increase renal responsiveness to antidiuretic hormone. Is this true or is this false? There are many parts of this question. Is this true? Is everything true or is it false? Huh. Listen, since TikTok went back, I said when TikTok went down, I was like, if it comes back, I'm gonna behave. I'm not gonna yell. I'm turning over a new leaf. So I'm not gonna yell. I've turned over a new this is a new Professor D. I'm not gonna yell. But I see only 17 of you guys said true. First and foremost. I feel like I threw you off when I said, is the whole entire thing true? The reason I asked you that question is because as students, you tend to see a question and only part of it is true, and you choose it as your answer when the whole entire thing should be true. And the whole entire thing here is true, but only 17 of you guys chose this, but I'm not going to yell. Only 17. I'm just going to talk to you. So, guys, indomethacin, which is an NSAID, it absolutely does increase the kidney's responsiveness to antidiuretic hormone. Remember, antidiuretic hormone, it makes you hold on to your fluids. So what it does is the kidneys recognizes this drug and it's more responsive. So instead of letting all the fluid go, the kidneys will do what? Reabsorb with an A. Remember, there has to be an A. It'll cause renal reabsorption in the tubules, okay? We don't know gentle teaching. I'm trying. I'm trying because listen, I said, please, if TikTok comes back, I won't yell. I don't know how long I'm going to be able to hold on to this promise, but I'm trying. All right, true or false? Fluid and hormone replacement is the cornerstone for SIADH. Is this true or is this false? Fluid and hormone replacement is the cornerstone for syndrome of inappropriate antidiuretic hormone. Is this true or is this false? Jessica says, I think of you when I take my test. Oh, I'm so happy I can help. I prefer you yelling. I remember it better. You guys don't know what you want. I get complaints when I yell. You like it? Okay. This is what we're doing. This is what we're doing. Okay. Okay. So, fluid and hormone replacement. At least more of you guys chose the correct answer than the wrong answer. I'm happy you said false. Fluid and hormone replacement. That means we'd be giving fluid and we'd be giving antidiuretic hormone. We wouldn't do that in SIADH because SIADH already has too much antidiuretic hormone. They're already holding on to too much fluid, so that would be false. This would be correct for diabetes insipidus, DI. In SIADH, you expect to see a low urine output and increased body weight. Okay, so in SIADH, you would expect to see a low urine output and an increased body weight. Is this true or is this false? And you know what? I amend my promise. My promise is not to yell in this video only. I'm not going to make it past this video. So I amend it. The Lord knows my heart. Very good. True. True. By now, you guys have SIDH down packed. Way too much antidiuretic hormone. You're holding on to too much fluids. You're going to gain weight. But the fluid is in the vascular space. It's in the vessels, not in the tissues. So they're not going to look swollen. They're not going to be edematous. All right. Select all and apply. What is diabetes insipidus characterized by? Select all that apply. Oliguria, polyuria, polydipsia, hyperglycemia, low urine specific gravity, and low serum osmolality. Diabetes insipidus. What is it characterized by? Hi, Tattlebrad. I'm happy you caught this live as well. Thank you, Yessie. Deselect all that applies, be the death of me. That's okay. That's why we're practicing now. Get them wrong with me so you get them right on the test. That's okay. You have to treat select all that apply as true or false. Each individual option, true or false, true or false, true or false, true or false. Don't try to group it together. That's how you get them wrong. By themselves, true or false. So the first one, oliguria. When it comes to DI, do we see oliguria, which is an abnormally low amount of urination? False. In DI, we see the opposite. They're urinating all over the place. And when I say all over the place, I'm talking about, guys, 2 to 20 liters of fluid a day. All right. So that's false. Polyuria, excessive urination. Absolutely. Polydipsia, excessive thirst. Absolutely. Think about it, guys. This patient is releasing all this fluid. Don't you think they're going to be thirsty? Of course, they're dehydrated from all this fluid they're releasing. Absolutely. Hyperglycemia. Look at you. 40 of you guys said yes. I threw that in there because I knew when you saw diabetes insipidus, automatically your brain was going to go to hyperglycemia. No, hyperglycemia is diabetes mellitus. That is blood sugar. That's when we're talking about hyperglycemia. In diabetes insipidus, that has nothing to do with blood sugar. It has to do with anti-diuretic hormone, not having enough of it. So no to hyperglycemia. That's false. Low urine specific gravity, true. Because in DI, you don't have enough anti-diuretic hormone. You're urinating all over the place. But even though you're urinating all over the place, again, guys, 2 to 20 liters of fluid per day, there's no solutes in that urine. All the solutes stay where? In the blood, right? So the serum, the serum osmolality will be high, but the specific gravity for urine, it's going to be low. There's no solutes. It's all in the blood. And then low serum osmolality. No, the serum is going to be high. That's where all the solutes are. It's going to be low in the urine, high in the blood. True or false? DI is caused by having too much antidiuretic hormone production or secretion. So DI is caused by having too much production of antidiuretic hormone or too much secretion of antidiuretic hormone. Is this true or is this false? Very good. False. You guys know that's false. Patient doesn't have enough antidiuretic hormone. That's why they are urinating all over the place. Type in your answer. In diabetes insipidus, is the urine output up or down? Simple as that. Just type up or down. Which is your answer? In diabetes insipidus, the urine output, is it up or is it down? Don't play with me, treasure. I said I wasn't going to yell. I didn't say anything about threatening. Thank you. Up. Diabetes insipidus, there is not enough antidiuretic hormone, so that patient's urinating all over the place. Urine output is increased. It is up. Let me see what you guys said. Oh, only 7 of you guys said down. Good job. Last question, true or false? Hypernatremia is seen in the patient with diabetes insipidus. Is this true or is this false? Hypernatremia is seen in the patient with diabetes insipidus. True or false? This is the last question, guys. Last slide, make it count. True. True. Remember, in DI, patient doesn't have enough antidiuretic hormones, so they're urinating all over the place. So there's large amounts of urine excretion, right? Large urine output, but it's just fluid because the solutes are not in the urine. They stayed in the blood. Solutes such as what? Sodium. So you're going to see hypernatremia. And plus, guess what? It's going to be concentrated because all the fluid's gone from the bloodstream. It's in the urine, right? Okay, guys. And that is it. Let's see how you guys did. Oh, before we go and look at the results, guys, don't forget to check out my website, nexusnursinginstitute.com. My Nexus Nursing Test Bank is coming out very soon, and it is for PN, VN, RN, and nurse practitioner students. If you're studying for NCLEX PN, VN, NCLEX RN, or your nurse practitioner certification exam, whether it's ANCC or AANP, guess what? I got the questions that you need to practice, the information that you need to know to pass your exam. So that's coming very soon. Check out my website, nexusnursinginstitute.com. All right, guys, let's see how you did.